Hello guys, my name is Bruno Gobbato. We are initiating our surgery in Brazil. We are speaking directly from Hospital Jaraguá in a city called Jaraguá do Sul. It's a very small city in the south part of Brazil. We are here with John Erickson from the United States. Hi John, nice to have you here.
Thanks for having me, Bruno.
Professor Thomas, hi. It's, this is
Hello,
a
Bruno.
wonderful evening in Brazil. It's nice to have you guys virtually here with me. And we are going to present the case first. So I will close you guys just for a second, and we are going to present the case. Just a second. So what we are using this kind of technology for today. This is a more simple surgery, and the objective today is not to show the actually the technique for the surgery itself, but how can mixed reality be part of our surgeries in any surgery, not only a arthroplasty, but a simple surgery just like a fracture or a plate removal and even a arthroscopy. That's what our goal for today. This patient is a male patient. He had a bike crash, and he had a fracture of the clavicle, a scapular body fracture, a spine fracture, and even a rib cage fracture. Now I think we are done. I have forgotten to introduce my nurse, Marisa. It's right in front of you. And Dr. Diogo right there is the anesthesiologist. We have the IT guy here, is also called Jonathan. Hi, Jonathan. So what we did the planning for this patient. We did the planning and the reduction of this fracture in computer, as you see in this video. So we choose the best plate for that case. And this is the planning. And here you can see the models. Let's check. First of all, we have here the reduction that we achieve on the computer. The patient has the Z-shaped fracture with two intermediate fractures. And this is the planning that we have for this patient. In red, we can see the locked screws, and in white, the cortical screws. So this is what we have planned on January for doing that surgery. I think here we have also a new model showing what we have planned for this patient. Okay, let's continue. So this is the post-op X-ray, as you can see here. And 1 year later, he has some pain. He has some subacromial pain, some bicital groove pain. We are not sure exactly why he still has pain in his shoulder. I did a subacromial injection, and he got better for some weeks. And then we planned today to remove this plate and do a shoulder arthroscopy. This is the model from the post-op 1 year. And here we can see the plate that was positioned. Now we are looking from the bottom part of the model. We can see here it's okay. The reduction is okay. The plate is okay. There are no screws that are perforating anywhere. So today we are going to do the removal of the plate and a shoulder arthroscopy. Of course, we are not today to show how to do a remove of a plate. This is a surgery. The technology is not for that, but this is for introduction you. So I'm going to show you the MRI of this patient. So the axial view, as you can see here, we have some liquid on the biceptal groove, probably something in the subscapularis, I'm not sure. I'm going to see on the arthroscopy, the coronal view. Do you have something in mind? He has some bursa. I'm not sure if this is artifact or not, but this patient has pain for 1 year. So we are going to do later arthroscopy.
Can I ask a question?
Of
Bruno?
course, Thomas.
Regarding the pain, do you have? You mentioned that all screws are not prone to the bones; they are not in the subarachnoid space, correct? Or is it possible
most
that
of the
one
pain, yes, he has most of the pain on the supremaclavicular. Yes, he has some impingement pain, Thomas, and he was better with a injection, but then he got worse. Of course, he done 60 or 70 PT sessions and did not went well. He has some pain over the clavicle. I'm not sure if his pain is because he has some nerve entrapment, superficial nerve entrapment, but he has for sure some subacromial pain. So as we wait to be time to remove the plate, to do only one surgery.
Yes.
As he wants to remove the plate, he's a very active patient. He does lots of sports, he does lots of biking. He has lots of friends that have already a clavicle fracture. Most of them remove their plate because they think it will break again. So he wants the plate to be removed. So that's what we are doing.
Of course.
We're removing the plate and doing a arthroscopy.
Okay.
Also,
of course. My point was
it's a diagnostic arthroscopy, probably nothing else.
Yeah.
We really think that this kind of technology would be very interesting when we do the first surgery for the fracture or for a osteotomy, for something like that. But this is, I would like to show how the technology, we can have everything in front of us. We can have the exams. We have the CT scan from the prior case. We have the CT scan from today, all in front of us in this mixed reality hologram.
My point was that the impingement could be due to the tip of one of the most lateral screws that could impinge sometimes with the supraspinatus.
You are totally correct, Thomas. You are totally correct. We are not sure, but for the image, it seems not to be, but we are going to remove it.
I agree with you. I agree with you.
Have you
tried to remove plate and wider weight local anesthesia, no tourniquet?
Okay. Not yet. I did not try Walland surgery for clavicle fracture. I know there are some guys doing. I really would like to do.
For this case,
yes. For this case, as I'm going to do a shoulder arthroscopy,
of course,
this patient is general anesthesia. This patient is in lateral decubitus. You're going to see here. We already have done the approach to take time because there is nothing interesting here in the approach. I'm just going to open the 3D model just to follow the surgery and the 3D model that we have prepared. Now I'm just going to remove the plate and the screws. Just a second. And we are going to go to the arthroscopy. We have just updated, of course, the app.
Bruno, just as a
John?
question in general, do you prefer the lateral decubitus position for most cases or all cases, or do you vary at all between beach chair and lateral decubitus positioning?
Well, I do lateral decubitus for all my arthroscopies, so that's why I done this in lateral decubitus, avoiding changing the patient. We are in a very small hospital, John, so we have very few people to help us. So in lateral decubitus is always better because I avoid having one people dealing with the arm. The arm is steady. It's one of my choices today to do in lateral decubitus. So I do almost everything in lateral decubitus.
Interesting.
This is something that we learn with some having some problems in the past. Yes.
Yeah,
Here
it makes
we
sense.
have the model.
Work with what you got. That's what we always say.
Yes.
So it makes sense.
So I think you already have the model here. So we have the patient is in lateral decubitus. This is the coracoid process, the anterior part of the clavicle, the posterior part, and we're going to follow the screws, okay, to remove it. So we already have done here the approach. There is nothing different from that. Let's, when camera is, we're going just to remove the screws. As you can see here, we have 4 screws, 5 screws, 4 screws, 1, 2, 3, 4, that are the medial screws. There are 3 cortical that you can see here in blue, and 1 in white here in the model that is the cortical screw. So we're going just to remove the screws.
Could you bend your head? Yeah.
Yes.
Thank you.
Yes, they are telling me. So here we have the white screw. I'm removing the white screw here. Here is the yellow. This is important when we are doing the first surgery, of course, to make sure we are in the correct position. 1 screw. Now we're going to the second screw. This screw like that. Of course, for removing, it's easy. Again,
Bruno?
This is important. Yes.
Just to close the discussion with Wallant, yes, there is a paper in the GACS that has just been published with the result of clavicular fracture performed under Wallant. But just to say that in our department, we're removing the plate even for clavicle fracture under Wallant.
Oh, nice.
And it works really well. And then our next step is to perform the fixation of fracture under Wallant. But we haven't tried yet.
I've been sort of moving that direction myself for certain cases, and I did a Lacertus release the other day and had that amazing result on the table where the patient has power back in their hand, and it's really it's such an incredible experience. So I think I obviously don't have experience in the clavicle with it, much like Bruno, but I can attest to the fact that the more I've been using it, the more I like it, and the more patients seem to like it. So just something to consider, Bruno. It's a great technique in general.
John, are you doing Wallant for what else?
I'm using it for probably 90% of my carpal tunnel releases.
Yes.
I'm using it for the Lacertus release. I use it for.
Do you do a lot of Lacertus?
Not many. I think it's one that is missed a lot, but it's not as common as just a standard carpal tunnel syndrome. But I think that there is a lot of use for it where it really where Don Lalonde really kind of pioneered it with for flexor tendon injuries, and that's where I think it's the nicest when I'm dealing with an injured tendon, and I can show the patient on the table and I can check the repair, what they can do. I think it's very empowering for people. So the more I've found places to use it, the happier I've been, the happier my patients have been.
And do you do the scratch test for your patients to do the diagnostic? How do you do?
I do, yeah. I really didn't do it even much in my fellowship, and I was a bit skeptical of it at first because it seems like magic, but it really is a powerful test. It's pretty impressive how much weakness in external rotation people will get when you stimulate the skin over a compressed nerve. I don't really have a great explanation for exactly why it works, and I'll have to read more of Sue McKinnon's work on that. But I've always been impressed when you find the right patient. It is a really pronounced examination finding.
I agree with you, John. I think the hand surgery and even elbow surgery has completely changed with Wallant, scratch collab test, and ultrasound scan. And combining physical exam and ultrasound scan makes the diagnostic so easy, so much straightforward. I think it's a really a fantastic time for hand surgery.
Just to show you, here we have the X-ray original from the patient. As you can see, the X-ray, it doesn't seem too much displaced. And when we do the 3D model, we can see how much this clavicle is displaced. We have here the medial part, the lateral part. We can see.
Could you place
your
model on a? Could you place a model? Sorry, Bruno. We can't see really the model because it's in front of a white wall. I don't know if you can place it.
Yes, oh, of course. Sorry. I
think
here will be better.
Yes, much better. It is much better.
So when we see the model in 3D, we know that we have contact bone here. So this will heal. Of course, this will heal. But in what cost? Yes, this is a big displacement. We can see here. So when patient and even an orthopedic surgeon see this kind of model and he sees, well, the clavicle will be like that, most of the patients doesn't want that, you know, because it's too displaced. Anyone will do a conservative. I think I might do conservative in some cases. In this case, of course, because of the displacement, the patient has a scapular fracture, non-displaced scapular fracture, but other lesions. I choose to operate him. But Thomas, would you have surgery on him?
Definitely.
Yeah. Surgery. You, John?
I agree. I think, like you mentioned, while the risk of non-union is probably relatively low, the risk of malunion, and I bet symptomatic malunion in a patient who is highly active, like you mentioned, for this gentleman who likes to ride his bicycle and do things where he's putting a good amount of load on that upper extremity, I think he would probably be more symptomatic. And while he, like you said, he probably would heal, I think he'll do better, with surgical intervention. So I would have offered this patient surgery as well.
So we have already removed the plate. There is nothing else to show here. And we're going to do a arthroscopy. So vamos colocar aqui a tração. Você consegue se ali ajustar aí, Marisa? I'm going to close these models. I'm going just to open here the 3D model, and I'm going to start the arthroscopy very quickly.
So just Bruno, just to tell you how we managed to do some arthroscopy with the HoloLens.
Yes, nice.
In fact, the tricks we use is we have a laptop and we connect with a graphic card the exit of the image from the column of arthroscopy to the graphic card of the computer. So with the AVI software, we can have this. We can use our computer as a monitor for the arthroscopy. Nice. And then we open a Teams call, and with the Teams call, we can have the image on the HoloLens. But there is still a little lag, so it's not as comfortable as with the normal monitor. But this is something that can be done. John, are you performing your shoulder arthroscopy in beach chair or in lateral recurrency?
In beach chair, yeah. I really have very limited experience in lateral decubits. I think that some of that actually came from my training in France, because in Lyon, in Dr. Walsh's clinic, and I think that they are almost exclusively in beach chair, and I think some of that comes from the comfort with the Latarjet procedure and using that as the most common form of anterior stabilization. And so if you're using that, then I think it makes sense where maybe you don't address the labrum quite as much. And I think there's still many tricks to address the labrum effectively in a beach chair position. I like to be in one standard position that I can use for many things. And so for that reason, I use the beach chair almost exclusively. But obviously there's good data, suggesting that the lateral decubit position is excellent, especially for labral repair. And I think that the reality is it has a lot to do with as a surgeon, what are you most comfortable with? And I think if you can do the right things in any area, then you'll be fine.
Okay, now we have a better image. Just a sec. John, ask your questions. I do the posterior approach normally and the anterior portal. Nothing different. We are looking here from behind. Let's check the cartilage from the glenoid. Seems to have the bare spot, but maybe some small glenoid lesion, but very small. Let's see, here we have the interval, here we have the subscapularis. Let's check better with another view. And let's see the long head of the biceps. That probably a 70-degree scope would be better to check, yes. But I think there is nothing here. I'm like the French. I really don't like biceps. Biceps, for me, it's I always cut. In older patients, I only cut. I don't do the tenodesis. But this is a young patient. For me, the biceps has not big deal. Let's check if he has a slap lesion. What do you think, guys? I don't think we have some debris here, but I don't think I will fix this slap lesion. John, what do you do when you have a slap lesion? Do you repair as a good American, or you do a tenotomy as a good French?
I'm biased by my French training, and also fortunately I published a systematic review on this, looking at the complication rates of patients over 35, and if you can have an excellent result with a labral repair, even in patients who are older, but they do tend to have I think a risk of being stiffer. And so some of the complications that occur is often if you over tighten someone, and many times I think you're dealing with a degenerative tear rather than maybe an acute traumatic pathology. I think you need to be very careful of that. So I'm much more inclined to do a biceps tenodesis. I would say that it's rare. If your mechanical symptoms of catching, clicking, locking come from a trauma and you're young, you're under 40 and active, then I would have a pretty low threshold to repair you. If you're older than that and there's any degenerative component to it, I would say that I'm going to perform a tenodesis. Thomas, what are your thoughts?
I'm very French. So no, and in France we have not a lot of picture as well. I think that's one of the main reasons. So first we have probably less slap lesions that you have in English-speaking countries, US and so on, but also India with all the pitcher for baseball or cricket and so on. So when we have a slap, generally it's not such an active patient. So we like to follow the guidelines of our multi-center French study that shows that far less risk of relief of remaining pain after biceps tenodesis than slap repair. So I'll go most of the time. So 9 times out of 10 for biceps tenodesis.
For students, I really like to show this image from my field of view, because here I can place, of course, this is the right shoulder. This is not a left shoulder. We are doing a left shoulder arthroscopy. I missed that, but we can here see the curve. We can teach students what we are doing, the field of view we are doing with these 3D holograms and showing them in the screen. And that's something that mixed reality is very important too for training for young surgeons, students, and then you do the surgery by yourself when we are ready. I'm going to do the subacromial space now. I'm not going to do anything with the biceps. It does not convince me that it needs to do something. We have some tenosynovitis, but I'm not going to perform a tenotomy. But I am a tenotomy guy. My nurse right here is with the scalpel ready, always for a tenotomy. but in this case, I'm not going to do an anatomy, neither a tenodesis. I'm going just to go to the subacromial space to check everything, and then we will probably are done for this surgery today, guys.
Did you create the model by yourself, Bruno?
No, John. This model was downloaded by a friend. His name is Yang Lee Moon. He's a South Korea guy. Now nice he owns his own hospital, so now he can lend me his models, whatever I need. But this is not a patient-specific model. All the models that you have seen today were from this patient actually. Okay, this is the only model that is not from this patient. This is a model just for teaching. And now we are going to do the subacromial space arthroscopy just to make sure everything is okay, the cuff is okay, to remove his bursa. And by doing that, we did a diagnostic arthroscopy. We have the plate removal. Let's check if we have some problems with the screws here, but I don't think we will have. And we are done for today. Again, we have learned a lot with you, Thomas, how to use this kind of technology, even for hand surgery. I think I followed some hand surgeries on your early start. Yes, some scaphoid surgery I think you have done. I really think mixed reality can be very useful when having different kind of surgeries, but we have to start in some point. So I really suggest the young surgeons to use, of course, in arthroplasty. But if you are a young surgeon, using a fracture, using a shoulder arthroscopy, that's a surgery that you are already, how can I say, you already know how to do it very well. And if any technology, you should start from the beginning. So I really suggest, of course, using the Heads Up app that was developed by Evolutis. It's an amazing app. With the tracking for the model is amazing. But I think we should always start with some very easy surgeries. And that's what I'm doing for today with you guys. I'm showing a easy surgery in the small part of the world, in the third world country, in a very small city, and showing that this kind of technology, just as a smartphone, can be used everywhere and for everyone. Everyone can use this kind of technology. We can use in France, we can use in the United States, but we can use in the small city in the south part of Brazil, we can use in Ukraine, we can use it everywhere. And it's useful for everywhere, even if you are a professor like Thomas, or even if you are an orthopedic surgeon like me, a general orthopedic surgeon that does most of the surgeries, does most of shoulder surgery as well. So
I think what you show, Bruno, very, very nicely is that you can link your simulation, because what you teach us is how to simulate a surgery by creating 3D models.
Yes.
And mixed reality is a very nice tool to complete that, because then your 3D model, you can have them with you during the surgery when you want, in an holographic mode.
As we were expecting, this patient would have lots of bleeding and very inflammatory subacromial space. In this kind of patient with pain, we always see this kind of surgery, a very red surgery, arthroscopy. So probably he has some synovitis. Here we have, as we can see, we have the bursa is very red. So I'm going to finish the surgery. And I think, do you have any questions? Would like to discuss something about the technology?
John, what do you think? You was about to tell us what you think about mixed reality and.
Well, I think Bruno touched on something really important as well, and I think this is true no matter where you are. This is a technology that is, it may seem somewhat expensive, but in comparison to, say, like a robot or, other high capital expenditure things that hospitals often are not interested in, or it's a very difficult selling point. This is something that is useful for so many things. As you've demonstrated, even in a case like this, you can use this to plan surgeries, to access information, to talk to other experts. And because it can be used again and again, it doesn't have to be sterilized. There's just so many ways that this augments, Thomas, to borrow sort of your phrase, really, the augmented surgeon. I mean, this is really what you've sort of taught us, how you're adding sort of layers of armor to your ability to do surgery. And so I think the more you use it, even if you're using it for simple cases, the better off, the more familiar you are with the device. And then you can start to use it, I think, more and more for more difficult cases where hopefully we'll find over time that it's improving our execution of those surgeries and improving our outcomes. Because I think that's ultimately what we want to show. And I think we're still, we're not quite there yet, but I think that we will be there soon. I think we'll be there very soon.
Yes, and I think, John, that this device will be just our smartphone. So right. we use it for everything. If Thomas comment today also this subject, we use for everything, and we will probably be using for everything. Maybe even a small surgery to have to see the patient notes from your office or the hospital. If I have some doubt, I can look it. I can check, as Thomas said, on the other surgeries also. We can have our experts, just as you, being in the surgery, in the surgery actually. As you can see here, we have a very thick bursa, and we are removing it. And if it was a difficult surgery, or if I was a fellow, I could be streaming it for Thomas, I could be streaming it for you, and we also could be having a event here, just as we are doing right now, streaming and showing different kind of surgeries. And I really think we do not we do not find yet how powerful is mixed reality actually. We are still discovering it, and I'm very thankful for Thomas having this opportunity to use this kind of device and test it and maybe push the limits a little bit forward. And I'm very thankful to be here with you guys today. It's been an amazing opportunity. Thank you, Microsoft. Thank you, Jonathan from Evolitis also. He's always there for us, and I hope we still connect and share our surgeries.
I think we will, Bruno. I think we will.
We are going to have more surgeries today. This is one of them. We have lots of arthroplasties for the next sessions, so you may stay tuned to learn lots about mixed reality with our experts all around the world.
Thanks for having us in your operating room, Bruno. We really appreciate it.
Thank you, Bruno.
Thank you, guys. Bye-bye.
Bye.
Bye-bye.
Thank you, John.
Thanks, Thomas.
Bye.